Good afternoon, dear colleagues, ladies and gentlemen. I would like to give you a very warm welcome on today's Urowebinar organized by the European School of Urology, titled Dealing with the Challenge of Infection in Urology in the COVID Era. My name is Béla Köves from Budapest, Hungary. I will moderate today's webinar, and we have two very interesting lectures in my opinion. The first one presented by Professor Florian Wagenlehner from Giessen, Germany, and he will talk about the background of the COVID-19 pandemic and about the virus itself, so it will be very informative. And the second lecture by Dr. Tandoğdu from London, UK, and he will talk about the importance and principles of mitigating nosocomial COVID-19 for elective urological surgery. So this will be a more practical lecture about how we can continue to work and perform surgeries the most safe way possible during our pandemics. So with this final note, I wish you a very fruitful webinar, and Professor Florian, I ask you to start your lecture.
Yeah, thank you very much, Béla. Dear colleagues, first I would like to thank the EAU and the European School of Urology for giving us this possibility to talk about the COVID-19. So I will give you a brief background on COVID-19 and maybe some recent developments. So as you all know, COVID-19, the virus itself, it was first detected in December 2019 in China as a similar virus to known coronaviruses, but full sequencing data showed that this virus is a virus of its own. It's closely related, but it's not one of the known viruses such as the MERS coronavirus or the SARS coronavirus. Like the other coronaviruses, this virus is an envelope virus. It's an enveloped RNA virus. The envelope contains high amount of lipids. And this is also some kind of a classification for viruses itself, because it has implications for hand hygiene, skin disinfection, instrument disinfection, and surface disinfection. Because viruses could be classified into enveloped and non-enveloped viruses, and all the enveloped viruses, they have a rather low stability to disinfection, whereas non-enveloped viruses, they have a high stability to disinfections, and you would need special disinfecting agents, virucidal disinfection agents. So this is not the case with the coronavirus. So all disinfectants that contain alcohol, lipid solvents, etc., are effective. And there are older in-depth investigations with older coronaviruses that show that all the available disinfecting agents such as sterilium, microbac, cortisol for surface disinfection, or ingredients for instrument disinfections are highly effective. So if we summarize that, for the coronavirus, we don't need specific infective agents. Disinfection, as usual, is effective for hand hygiene, for skin disinfection, for instrument disinfection, and for surface disinfection. Now we'll go to the pandemic, and these are the data as of today. So for the time being, as of today, we have almost 12 million confirmed cases all over the world. And you see here in this WHO spreadsheet that basically the whole world is affected. There is no single country that is not affected at all. There are large heterogeneities between the countries and the regions, but the whole world is affected. Therefore, it's indeed a pandemic. 12 million cases, 500,000 deaths. So if we look at the different regions and how is it developing, so this is as of today, and you clearly see here that the pandemic is in full blow. It's still delivering increasing rates of infected patients. The distribution is changing over the time. Initially, as you all know, it was in China. Then the wave hit Europe, and pretty close after that, pretty soon after that, it first hit North America, and now it's in a full in whole America, still with increasing infection rates. And now other Asian countries like India, for example, are coming, and also we have increasing rates from Africa. So how is the situation in Europe? These are other data from the European Centers for Disease Control. So the highest impact on Europe has been during March and April. So this is certainly, this wave is over. But as you see here, we are at a certain baseline numbers, which account for around 5,000 new infections in whole Europe each day. So there is, in Europe, we still have a rather high baseline level of novel infections. So this is, again, very different in different regions. Even this is, for example, just the chart map of today, where the cases of last 7 days are depicted in even in the smaller zones. And you see here there are some outbreak regions in Germany where specific measures would be or would apply. So what is the death rate? Again, this is from the WHO, and you see here in March, April, May, we have a rather homogeneous death rate. There were some outbursts, but in general, the death rates are ongoing on a worldwide level, on a rather high level. And for Europe, there is also a website that looks into excess mortality, because of course, you have mortality continuously throughout the years. But for example, if you look at the last 4 years, there is always some kind of an increased excess mortality, at least in 2017, 2018, during the winter months, during the winter and January, February months. This was in 2017-18, this was attributed to the influenza outbreak. So in 2019, it was a bit diminished. And now in 2020, you see here in Europe, we have an excess mortality, which is basically due to the coronavirus, also a little later in the year, but this is definitely attributed to this pandemic. So pathophysiology. There's still a lot to learn, but from what we know, of course, is that we have different attack rates. We have patients that are almost entirely asymptomatic. We have patients that have a mild infection, and we have patients that are severely infected. And for the time being, it is we are far from fully understand why we have so very different forms of infection. Probably as the first topical part of the body is the upper respiratory tract and the lung, and it is probably the immune capacity at these areas. For example, here in the lung, the full picture of the immunological situation between macrophages stimulating T cells plays a pivotal role. Perhaps, this is also not yet clear, but perhaps the virus can also affect the T cells itself. Similar as the HIV virus, also T cells don't have the receptor, the angiotensin converting enzyme receptor 2, which is the receptor for the coronavirus in the upper respiratory tract and in the lung epithelial cells. But apparently there's a not fully understood immune scenario that might be able to prevent from more severe infections. If there is a severe infection, then we have pretty much a sepsis-like scenario with a pro-inflammatory phase and an anti-inflammatory phase where other organs are also affected. So, for example, this is a recent paper as of today from the New England Journal of Medicine, where autopsy data have been published. So this is the typical lung affected by the COVID-19 virus, and as you see here, there is a large immune infiltrating scenario in the lungs, and there is also in the very small lung capillaries very frequently capillary coagulation, capillary thrombosis. And in electron microscopic investigations where a normal lung capillary bed has been compared to the COVID-19 capillary bed, or with a patient lung with the COVID-19 capillary bed, you see large dysregulations in the capillary bed in the lung. And there is also a high neoangiogenesis in patients that are affected in the lung capillary bed that are affected by COVID-19. So in urology, we might be also affected by the kidney part of the systemic infection of the virus, and the kidney is very frequently affected in patients that suffer from COVID-19 infection. More than 40% of patients that are admitted to the hospital have proteinuria as a sign of some kind of renal affection. Then 40% of the patients that are in the hospital are admitted to ICU, and 40% that are admitted to ICU have acute kidney failure, acute kidney insufficiency, and 20% of these patients that are admitted to ICU need renal replacement therapy. So the kidneys for several pathological and pathophysiological pathways are affected either via the course of the sepsis, via the course of the shock, or because also the kidney has receptors for COVID-19, for the virus, and so there might also be a direct effect of coronavirus to the kidneys. So there are several publications that depict the clinical scenarios. This is from a nice publication that looked into more than 1,000 patients from China. And the median age of patients that have been admitted to hospital was 47 years. So it is not the case that only the old people suffer from coronavirus disease. It's rather a median age population. At admission, only 40% had fever. During the hospital stay, almost 90% had fever. Cough was seen in 2/3 of the patient. About a quarter had coexisting illnesses. 15% had a severe illness. Abnormal CT scan was seen almost in almost 90% of the patients. A hallmark is also lymphocytopenia. As I've said, there might be a direct effect of the viruses to T cells, for example. 5% of patients had been admitted to ICU. 2.3% needed mechanical ventilation, and 1.4% of patients admitted to the hospital died. So this is a rather realistic. These are realistic data and has been seen in other publications as well. So this is a case vignette of a more or less typical patient that presents to the hospital. This was a 50-year-old, previously healthy man that presented to the emergency department. He presented with worsening dyspnea that was 2 days since happening. Since 2 days, he had fever, cough, fatigue the week before, and he appears acutely ill. Has fever 39.5 degrees Celsius. The heart rate is elevated, 110 beats per minute. Respiratory rate is highly increased, 24 breaths per minute. Blood pressure is still normal, 130 to 60. Oxygen saturation, ambient air, is significantly decreased at 87%, and he has lymphopenia. So this is always might be a hallmark. Has lymphopenia, so differential blood count might be useful to do. So in such a case scenario, we have 2 things to keep in mind. As with infection in general, we always have to think about infection control, and in the coronavirus, because of the high contagiousness, this is a pivotal hallmark. So infection control and healthcare protection is a very important aspect we need to do in the first line also. And there are some very nice data, because there is always some discussion about preventive methods. So for example, do face masks prevent viral shedding? Yes, this is a recent publication where you can see and this has been performed in patients that were infected with coronavirus, compared to patients that were infected with influenza virus, and compared to patients that were infected with rhinoviruses. And you can see here that in the coronavirus patients, if they used a face mask, it made a large difference. The droplets, so these are particles that are larger than 5 micromilliliters, were completely absorbed with the mask. And even the aerosol, the particles that have a smaller diameter, are absorbed by the face mask. So the face masks are highly effective. Influenza virus, there was also some kind of a protective effect, but more in the larger droplets, less in the smaller droplets. And for example, in rhinoviruses, the face mask was not effective at all. So therefore, in coronavirus, yes, face masks are effective. Now, personal protective equipment is also, there is even a Cochrane database that included recent data also for coronaviruses. And just to summarize that, yes, of course, personal protective equipment is, of course, effective. So the problem is you can make it very complicated, and that has also drawbacks in the donning and doffing of the personal protective equipment. So probably lower level protective equipments are more or less similarly effective. So, and the second part is how to manage the patient. Of course, we need a diagnosis. And I just give you some data on the sensitivity of the different diagnostic tests in the case of a point of care scenario in the hospital in the first day. So PCR has a sensitivity of around 70%. If you repeat it, sensitivity increases, but it does not have 100% sensitivity. Serology in the first week is very low. The sensitivity is around 30% in the first week, increases to 70% in the second week, and then increases to around 90% in the third week. What about chest CT? Chest CT in symptomatic patients has a rather high sensitivity of 90%. So this is the pooled positive rate of abnormal CT findings in patients that are symptomatic. So chest CT is certainly a rather sensitive diagnostic tool. So what about virological assessments? This is a nice publication where 10 patients with symptomatic coronavirus infection have been heavily investigated by swabs of the upper respiratory tract, by the sputum, stool, serum, and urine at different time points from onset of the disease. And there were positive throat swabs over the first 14 days in most of these patients. Sputum and stool, especially sputum was positive, but stool was also positive up to 14 days. However, in the stool, it is still debatable if there is infectious virus present, but virus can be detected in the stool. There was no detection in the urine. And from day 7 on, patients started to become seroconverted. So after day 14, almost 100%. So in the second week, 100%. So 10 of the 10 patients seroconverted. So this is apparently what one can expect of serology in these patients. So you probably have seen a lot of these, publications where the different patchy CT scan findings are seen, in most of the cases even bilateral. So they're quite specific for detecting coronavirus, especially in these times, because everybody thinks about coronavirus. So how can we treat the patient? Because the patient may rapidly become critically ill with acute respiratory distress syndrome. So even if he does not need to go to ICU, he needs to be closely followed up, because he could very quickly become critically ill. And then it is very critical to decide if he needs to be intubated endotracheally. If he needs intubation, then as with other septic cases, and lung protective ventilation is important because so the plateau pressure needs to be below 30 centimeters water, because otherwise acute respiratory distress syndrome might ensue. And in refractory hypoxemia, the patient needs prone positioning, which shifts the blood from the blood perfusion mismatch to the better perfused areas of the lung. And then, yes, thrombosis and renal failure are well recognized complications and need to be dealt with. What can we do for the treatment of the virus infection itself? And you have heard probably a lot of rumor about different antiviral agents. For example, in vitro data show that chloroquine, hydroxychloroquine, other virus antiviral agents such as lopinavir or remdesivir have in vitro activity against coronavirus. So far, the clinical evidence is in all these four agents is rather low. Only with remdesivir there is a small there is evidence from rather small trials that it might be effective and might shorten the time of the infection. There is no superiority currently for mortality, but it might shorten the disease. And then there are other immune-based agents, even interleukin inhibitors of different cytokines, and there are clinical trials going on if this might be effective. For the time being, none of the agents can be recommended currently, but maybe some of the immune modulating agents might have a role. So in summary, I think what I've showed you that the pandemic is certainly not over. We have regionally very different courses and numbers. There are countries where the pandemic is not over yet, but where the pandemic is better controlled, but there are other countries and regions where the pandemic is just starting. So, and therefore, we have really to be careful still for the continuous pandemic, which is seen over worldwide. Then the virus itself is an envelope virus. It is susceptible to usual disinfections. So we have no specific problem with hand hygiene, instrument disinfection, and so on and so forth. We find infectious viruses in the airway samples, upper and lower respiratory airway samples. So there is still a debate if there is a virus in the urine. It's not convincing yet. There's also debate if we would find virus in the ejaculate. So that could be something that chronic carrier status could be the result from. If we treat, we have two things we need to address. The first is infection control and healthcare protection, and the second is the treatment of the individual patient. Healthcare protection, yes, face masks decrease shedding, especially in the coronavirus infected patients, and personal protective equipment is certainly effective. So there might be a discussion about what is the level of the personal protective equipment, but it is certainly effective. With the treatment in general is aligned to the sepsis treatment. For the time being, it's a supportive treatment, and we should keep in mind the different affected organs, such as the lung and the kidney, and organ support in the intensive care is something certainly that is important. So thank you very much for listening, and I would be happy to address questions.
Yep. Thank you very much, Florian, for this excellent presentation. To start the discussion, my first question to you would be, you showed us that viral numbers are still very, very high. Do we know anything, or can we extrapolate something about the natural course of this pandemic? Because historically, these viral pandemics usually took a few years, minimum 1 or 2 years, to run their natural courses. So can we expect the same here, or it's impossible to guess?
Well, of course, it's very difficult to look into the future, but as you said, from the historical perspectives, we know that it's not over within a year. And you've seen just the rate. If you look into the incidence rate, they are increasing on a worldwide basis. Currently, they're still increasing from day to day. So I would be very cautious to say that this pandemic will be over at the end of the year. So I think, personally, I think that we will at least live with this pandemic into the next year.
Yeah, thank you very much. And we have a question about masks. So we know, and you said that they prevent shredding of the virus, but it's a valid question: that does the mask protect the wearer, the person who wears the mask, or only the surrounding?
Yeah, that is a very important question. As you know, there are different types of masks. So there are masks that also protect the wearer. These are more, let's say, expensive masks. They are more difficult to wear because it's hard to breathe. So therefore, these high protective masks, they have a role in the protection, for example, if you deal with highly infected patients. But the other masks, they protect the environment. And if everybody wears a mask, then we have a mass protective effect. So therefore, from political reasons, a mask recommendation would make sense, even if it is not the high protective masks.
Yeah, thank you. We have a few questions regarding, as I see, chest CT and some specifics about surgical procedures, but I think we will wait the second lecture with these questions, because Zafar might address these issues. But a specific question about treatment: do you have anything about the role of plasma therapy?
Yeah, plasma therapy, this is used in the sense that those patients who have seroconverted might have antibodies that could be used for other patients to treat. So in the light of not having a vaccination currently, this is something where studies are ongoing to have the antibodies from other patients absorbed via plasmapheresis and use those as a treatment modality in those patients that are affected. There are some evidence that this could be something that could be used, but I think, as far as I know, there are worldwide several studies that are looking into that.
Yes, thank you very much. And you mentioned that the virus is not in the urine, so that's, I think, good for urologists. And there are several questions about other fluids. So do we have any knowledge about fecal transmission? And also for surgeons, do we know if the virus can be transmitted by surgical smoke? That might be relevant.
Yeah, that might be relevant. So the feces, as I've shown you in this one study, harbored virus, so that could be detected via PCR. But as you know, PCR also detects dead virus. So it's not clear still from the feces if indeed infectious viral agents are there, but it could be a possible infectious source. And for the time being, with blood, it seems that infectious particles for the time being are not detected, although we know that probably in the blood there is viruses, but this virus might be harbored in cells such as lymphocytes or macrophages. So with regards to smoke and for example, if we operate on patients, I don't know if Zafar probably will also target on that. There's no convincing evidence that if we have coagulated smoke or if we have contact with blood, that this might be infectious.
Yeah, excellent. And can you recommend any specific agent for instrument disinfection, or should we keep our standard procedure?
No, I think we can keep the standard procedures, because this is just the same as with other viruses where we have continuously infective episodes. So there needs to be no very specific infectious program for this virus, such as in rotaviruses, for example.
Yeah, and can we, I mean, there is also before the virus, there was this huge discussion about transperineal biopsies, the risk of infection in transperineal versus transrectal biopsies. Is in some way this pandemic affects this? Can we say that the transperineal biopsies are more safe regarding viral transmission?
Well, the transrectal biopsies would inoculate the viruses into the bloodstream if there is infectious virus in the feces in the rectum. So I don't think that the transrectal prostate biopsy would have a higher infectious risk regarding the virus, but we know, of course, that the transrectal prostate biopsy has a higher infectious risk regarding bacteria that are inoculated. Therefore, in general, yes, I would prefer transperineal biopsies for this kind of reason, not for the virus, for the coronavirus.
Yeah, I agree. I completely agree. And we have a specific question about acute kidney injury. Can we distinguish acute kidney injury caused by the sepsis or by the direct infection of the kidney by the COVID infection?
Not that I would know. This is still open for research. Probably it's a heterogeneous scenario that the virus might affect certain parts of the kidney by direct docking through the ACE2 receptor, and then of course these patients are in severe sepsis, they are in septic shock, so it's probably a mixture of different pathophysiological pathways.
Yeah, and there we have a question about if the virus can be transmitted sexually, but I guess it's related to the ejaculate, which we don't have any knowledge about.
Yeah, we don't know that yet. There are publications that did not find viruses in the ejaculate. There are some publications where in a part of the patient's virus has been detected in about 15 to 20% of men. There is also publications where perhaps the male patients would have had a clinical picture such as an orchitis. I think it would be a very important question to address, because we know that many viruses are found. For example, Zika virus was one of the recent virus diseases where viruses have been found in the ejaculate even after weeks and months. And that would mean that even asymptomatic patients infected by the virus could be carriers, and that would have a high implications for further management.
Yeah, and we have two questions related regarding treatment, and we have many questions for specific urologic surgical procedures and aspects. And again, we'll wait Zafer's presentations with those questions, because he will be very detailed in the practical aspect. But we have a general question. Do we have any knowledge about early steroid therapy? This is something which might halt the virus?
Yes, there are conflicting results with the steroids, corticosteroids results, as with the sepsis in general. As you know, corticosteroids have always been used in septic patients with very conflicting results. So for the day of today, I don't think it is a general recommendation to give every patient corticosteroids, because in sepsis we have several phases. After the pro-inflammatory phase, we have a counter-regulatory phase, and there the patients are more vulnerable to secondary infections, and this phase would be would also be supported by corticosteroids, and we don't want them to be immunosuppressed. And of course, corticosteroids in general would, as they are not very specific in the inflammatory phase, they would also suppress the inflammatory system. So in general, we cannot recommend corticosteroids in all the patients.
Yeah. And the last question for Professor Wagenlehner, then we move on to Zafer's lecture. In RDS patients, should we reduce or increase fluid therapy? Do you have any?
Yeah, in general, it's rather reducing fluid therapy. So in RDS patients, one has to be very cautious about fluid therapy, because otherwise the patients go into lung edema. So this is and therefore this is a very critical phase where the intensivist has a high responsibility, and of course it's always the dilemma to have the shock treated, right? And on the other hand, to have the patients overloaded with fluid, then he would go into lung edema. Therefore, it's a very, probably hemodynamic monitoring is a very important instrument in these patients.
Yeah, thank you very much, Florian, and also for this very nice discussion. We got answers to many, many good questions also outside of urology. And with this, I would like to ask Zafer Tandoğdu to give his lecture. Please, Zafer.
Thank you very much, Bella. Thank you very much, Florian, for your great presentation. So I'm going to be talking about moving away from the arena of direct treatment, pathophysiology of COVID, and moving a bit towards urology. And for those of us who are keen and want to continue treating our patients with surgery, elective surgery, predominantly I'll be talking about what's the measures we need to put into place to ensure a safe environment, not only for the patients, but for the healthcare workers also, because there's a nosocomial infection aspect to this, as it can easily spread around. So my presentation will last approximately 20-25 minutes. At the end, I'll be taking the questions, and hopefully I'll be able to answer them. This is the outline of what I'll be talking about. But before diving into the details, I just want to give a summary, actually, of what I'm trying to say. As Florian has mentioned, diagnostics are inaccurate for COVID. This creates a problem for us. There's asymptomatic carriers, and these people can be contagious. Patients and healthcare workers are under risk of potential hospital outbreaks of COVID-19. And at any time point, we cannot be certain about who actually is contagious. Therefore, it is inherently our first reaction that we want to eliminate the risks, but unfortunately, we cannot eliminate risk. And I'll explain what elimination and reduction, the differences are. So let's go into COVID-19 and surgery. I think this beautiful work done by my colleagues, and they presented their results in European Urology recently, in an international survey they've done throughout the whole globe. I think there's only a few countries they couldn't capture. 13% of urologists were advised not to wear a face mask at work from the fear that they're going to scare their patients. So I think exposing our healthcare workers, doctors, nurses, everyone in the department working there without a mask, and this trying to be encouraged, tells me that what we're going to talk about today is quite relevant. And if there's such any departments, which I hope there's not any left like that in the world now, what I'm going to say can convince them. So briefly, which Florian already said, mortality rate is estimated to be 2.3%, but this can vary depending on the healthcare setting, region, time, age groups, and comorbidities, of course, which I will not go into the details. We're all aware of the comorbidities. With comorbidities, the chances of unfavorable outcomes increase. And in a recent publication now, we know actually, you can see that these has been broken into two parts. At the beginning of the pandemic, it was thought there was a long list of comorbidities that were thought to increase mortality. Now there's possible risk factors, and there are definite risk factors, which you can see on this slide. And these are relevant from our point of view in prioritizing patients, risk management for surgery. Now, a beautiful paper recently been published in Lancet by COVID Surge Collaborative Group, who have surveyed over 1,000 patients, 1,128 to be accurate. And all of these patients were either diagnosed with COVID at the time they were having surgery, or they developed COVID, they were diagnosed with COVID within a week after surgery. So this tells us what is the implications of operating on a patient who has COVID or who develops COVID after surgery. I'll start with pulmonary complications first of all. Pulmonary complications from the pre-COVID era, looking at these large international surveys, is thought to be around 8%. And this includes mild pulmonary complications also. When we come into the COVID era, from the publication I've been referring to, it goes up to 51% in patients who have COVID, of course. Well, COVID does create pulmonary complications, you might say, but these are patients who have severe pulmonary complications, ending up in acute respiratory distress, intubated, or so on and so forth. So there is a dramatic increase in pulmonary complications. What about mortality rates? Well, pre-COVID era, the highest mortality rate reported is around 5.4%. And bear in mind what you see here is emergency laparotomy cases. So within the COVID era, in patients with COVID, this has gone up to 23%. So 1 out of 4 patients, unfortunately, had passed away in this cohort that was published. And those who had pulmonary complications versus those without a pulmonary complication, you can see that mortality is correlated with the pulmonary impact of COVID. So this all helps us actually now, this information, to understand that we really need to protect our patients from COVID after and before for elective surgery. Here, despite the rates of mortality seem different at the first glance for emergency versus elective surgery in this cohort, actually on further analysis, the investigators have found out that it didn't have a major impact. But amongst all these risk factors you see here that I mentioned previously also, because it was a very rapid publication, a very rapid study, they looked into these risk factors I'm listing on the screen on the right-hand side. And they identified that elderly people, males, high ASA score, multiple comorbidities, surgery for cancer, emergency surgery, and major surgery were all related to the unfavorable outcomes out of operating on COVID patients. So this really mirrors what we found previously, what was being previously published in terms of comorbidities and the relationship with unfavorable outcomes. So to wrap this section up now, what we know is that patients with COVID-19 essentially are under high risk of mortality and pulmonary complications if they are to undergo surgery. Therefore, we do not want to operate on people who have COVID-19 until we know they're recovered, which brings other questions that I'll try to answer. We want to operate on people who haven't got COVID. Now, patients who develop COVID after surgery also are under high risk of these complications. Therefore, we want to protect our patients not to develop COVID after surgery. And suddenly, this simple chart you see here brings a massive challenge in terms of developing our pathways and implementing this in a hospital setting. Now, at the beginning of the pandemic, we were aware of these challenges. And what I'll be presenting to you after this stage will be a consensus meeting we had carried out with a large group of infectious disease experts, surgeons that had looked into every item. And we tried to structure pathways in terms of preventing infections before, after, and within hospital. So at the beginning, I mentioned about risk reduction instead of risk elimination. The risk here we're talking about is coronavirus. To eliminate the risk, we either have to take away surgery or we have to take away the coronavirus. Since surgery is necessary for the treatment of our patients, then we can't take that away. We can't take coronavirus away. So what we're left with is risk reduction until we're over the pandemic, hopefully, one day. So this needs us to implement very strict processes, personal protective equipment used in a very rational way. So I'm going to go through those now. And to establish your pathways in your local setting, and which I'm sure most of us have by now done this, includes taking into account the dynamics of the patient, the hospital, and the healthcare workforce. And we can go through multiple examples of how these can be implemented, but what we're essentially trying to achieve is prevention of complications due to COVID and nosocomial infections. And if there's a nosocomial infection, we need to control it. So what we know is we need to operate on someone who's not got an infection, because these are the two things we know. It's dangerous to operate on them, and they can transmit the virus. Challenges are the diagnostics and the asymptomatic patients. So the strategies we came up with are either symptom check, isolation, or testing for securing a safe pathway prior to surgery. In order to understand this, we first need to understand the cause of the disease and the contagiousness. Florian went into the pathophysiology. I'm going to come to the daily practice of this. Once an individual is exposed to the virus, it can take up to 99% of patients have an incubation period of 14 days, median being 5 days. So this gives you a gap of 14 days. And in an ideal world, at least we would have known that patients who develop symptoms would be enough for us to triage them. Unfortunately, 30–40% who remain asymptomatic will not reveal any symptoms, and you will not know if they've got the virus, if they're a carrier and spreading it, or they're under risk. Now, those who are asymptomatic, when they did a chest CT scan on these people, it was noticed that almost 70% of them had some kind of changes in their lungs. Therefore, again, even if you're operating on someone who's a carrier and is asymptomatic, they're still theoretically under high risk of developing complications following surgery. So how can we reliably diagnose it? Which this is the slide that Florian presented, but a sensitivity of 70%, just to reiterate this. Serology, very weak, because it gradually develops, but we don't know if it's sustained. And chest CT scan, which has been questioned previously, there is no finding that can rule in or rule out COVID-19. You can know there's a lung lesion, but it will not tell you if this is COVID-19. And if it's a clear CT scan, you will not definitely for sure know if your patient is an asymptomatic carrier or not. So we're faced with scenarios such as like this. We've got men who are waiting for TRPs now, despite who are on alpha blockers with worsening symptoms, or they have a catheter indwelling. They have a few comorbidities, hypertension on ACE inhibitors. They think they haven't had COVID, but we don't know. So we're left in the dilemma that should we be swapping these patients? Should we be isolating these patients? And this will be depending on the local incidence of COVID. And also it will be dependent on your local resources. So every country in the world will be doing something different. And just to give you a bit of sense about it, we spoke about the sensitivity and of PCR swabs. And to give a bit more insight, swabs can be very different sensitivity depending on where it's taken also, with a false positive rate ranging from 8 to 40%, which is dependent on your lab. So one PCR test might not be the same with the other one. So would you be operating in a clinical, in a very pragmatic way, would you be willing to operate on someone after what I said with a single negative PCR test only, if there is asymptomatic? And the answer to that is no, we don't advocate that. A repeat swab is being advocated by CDC, and ideally within 48 hours apart, 2 swabs will increase your sensitivity, but you're still around 90–95%, so you're missing out on patients. And bear in mind the consequences of missing out of this is very, very high. So testing-based strategies alone are not reliable. How about isolating strategies? Again, the incubation period, 99% of the time being 14 days. The idea is to isolate someone for 14 days, don't do anything else, and then take them into surgery if they remain asymptomatic. Now, this theoretically sounds good, but we know that, which I'm showing on the right-hand side, blue corner of the screen, there's approximately 54% adherence to self-isolation, unless there's an incentive that can push it up to 94%, but this is dependent on the culture, on the environment, and the kind of incentives you're putting into place. So isolation-based triaging prior to surgery can be unreliable due to compliance. Now, one study at the very beginning of the pandemic at Taiwan, by using digital tracking, has managed to achieve isolation compliance rates at over 99%. Yet this is something of a big debate. In the UK, tracking devices, sorry, I misspelled that, there's a typo on the slide, but tracking devices are not very well welcomed in some countries. So it's difficult in terms of achieving isolation. This next step we need to talk about is, so we spoke about how to prevent. How about nosocomial infections? So you bring in someone and you don't know if they've got the infection. They're fine, but they can spread the virus, right? Yeah, okay. So I was talking about nosocomial infections at this stage. And in order to be able to understand nosocomial infections, we need to be thinking about the contagiousness stages of the disease. We know it can take 14 days to become symptomatic, but the contagiousness is thought to be at the peak around 2 to 3 days prior to symptoms, and it's unclear when the contagiousness ends, but probably after the symptoms resolve, someone is not contagious anymore. But this is not quite clear yet, so we need to be careful about this also. So we can take two approaches in terms of if our aim is to prevent spread of the virus in a hospital. We can take a symptom-based approach, or again, we can take a test-based approach. CDC suggests that if someone is asymptomatic and it's been 10 days since their first symptoms, they need to have 3 consecutive days since their recovery. An alternative to that is the test-based strategy, and you have to have the patients to have their resolution of fever, improvement in symptoms, and 2 negative swab tests, which are at least 24 hours apart of each other. So this is to prevent the virus from spreading. So to just recap what I said, symptom or testing-based approach prior to surgery alone is not reliable. Patients can be still contagious in their incubation period or asymptomatic carriers, which is, from a clinical point of view, is the same thing. People are asymptomatic. The incubation period is between 2 to 14 days, median 5. Contagiousness of asymptomatic individuals is thought to be around 10 to 14 days. Swab test sensitivity is around 70 to 80%, can be increased by a second swab. So we've got these three strategies. How do we implement them is the key question. Option 1 of no intervention, I think this is out of the question. As long as the virus is circulating in population, it's dangerous. Isolation only, we spoke about it. Compliance is an issue. Isolation and screening. So you screen the patient, they go into isolation, they remain asymptomatic, then you can operate on them. Based on our calculations, we think this gives 99% reliability. Screening only, this can give you a 90-95% reliability if you do double swabs, 48 hours apart of each other. So if you're going to isolate someone, if that's your strategy you're going to prevent an COVID, how long and what's the implications? If you're going for symptoms, what do you need to look at? If you're going for swabs, how many? We're advocating that as the ESIO also, and it's in alliance with the World Health Organization, CDC, and all international organizations. Isolate and screen. So you screen the patient at the beginning of isolation. They have a short isolation period, and they get their repeat the swab in 48 hours. This strategy can give you around a reliability of 90–95%. You isolate the patient, and this is a long isolation. You screen them at the beginning of isolation. This first swab is debatable, but the reason for that, so you have a patient for 14 days, 99% you cover them, they remain asymptomatic. You screen them at the beginning. The reason for that is their surgery is on day 15, and you're booking your theatre space for them. If you have a very tight theatre space like we do have here, then you need to ensure that your theatres is optimally booked and arranged. So you don't want your patient to be in the situation that you're putting someone in isolation when they have a virus, and on day 5 they become symptomatic. But this is an option. This is not definitely something we're advocating. Strategy 3, double swabbing. You swab at the beginning for the purposes I said, and you swab at the end of day 14. Now this day 14 swab, this is for compliance purposes. As I said, people might not be compliant to self-isolation. Although we think it's around 90% in our own cohort, it's still that 10% can be very dangerous in an outbreak in your hospital. So your second swab will prevent you from, will detect those who possibly were not compliant to their self-isolation. And I'm coming to the end now, very close to the end. In addition to all of these, what other measures do we have to prevent nosocomial COVID? We can use telemedicine. We need to reconfigure our pathways, and we need to reconfigure our hospital pathways also. The entrance doors, the exit doors, all sites. It is very, very difficult, I understand. I briefly want to talk about telemedicine. It is thought that this can reduce the footfall in a hospital by 20 to 40%. But the disadvantage of this is here that it's only accessible for people who afford a smartphone and are literate in using them. And depending on the area you work in this might be very variable. So it's not equitable. So we can't rely on telemedicine only. It is difficult to set up. Your hospital needs to set this up. Administratively, you need a very good support to arrange all your clinics into telemedicine, and you need the technology in place. So it sounds good, but it's not always that straightforward. In terms of reconfiguring your pathways, these 3 papers I think are very relevant, published in European Urology. Rapid guidelines were updated at the very early stages for BCG treatment and for how should we triage our patients. One thing I would like to say, having read these in detail, there will be parts of this that you will disagree with, and the authors of all these 3 papers highlight this. This is a general guidance for people to adjust it for their own needs in their own departments. And we have done such things. We have reconfigured our whole pathways for certain conditions, but I'm not going into the details. I'm just trying to highlight the principles here. So in summary, we need to implement risk reduction pathways. Mostly I spoke about the preoperative pathways, but these need to be locally applicable, such as telemedicine, the duration of isolation, swabbing intervals. If possible, telemedicine is very useful. And one final thing, due to the limitation of time, I think I exceeded my time already, it's about consenting. A recent paper that came out in BMJ has highlighted the importance of consenting about the possible outcomes of COVID-19 if it develops after surgery. Because we're assuming that we're taking in our patients without their COVID-free, but we're not 100% sure about that. So our patients need to know this, and our patients need to be consented for this also. So thank you very much for your patience, and both Florian and myself, I think we're ready to take our questions.
Okay. Thank you very much, Zafar, for your excellent lecture. We heard many very practical information, and you already answered many of the questions we having in the question room. There is one question, and it relates to both of your presentation, and it's about chest CT, and we also discussed this internally a lot. So if chest CT has so high sensitivity, or if it's reported sensitivity, why major societies do not recommend chest CT for the diagnosis? You mentioned this in your lecture, but can you give a short summary about it?
Yes, so a sensitivity of over 90% has been reported in some papers. Now, CT is sensitive above 90% if the patient is symptomatic. But we're dealing with patients who are asymptomatic and we want to put them through surgery. So at that cohort, it is not clear its sensitivity and specificity in terms of picking up COVID-19. That's one. Two, even if you find something on the CT scan, it can't definitely tell you that this is COVID-19. To break it down a bit more, when they calculate the sensitivity, they're assuming that 70% of the patients have ground glass images, and the remaining 20–25% have got atypical findings. Now, that atypical finding could be through another virus, it could be RSV, it could be influenza, it could be anything else. So looking at that, we can say that if you do a CT scan and you see a chest lesion, yes, don't operate on the patient, investigate further. But to use it as a populational screening tool prior to surgery, it hasn't got that reliability, and you're exposing people to so much radiation constantly. Probably no healthcare system will be able to cope up with that, I suspect.
Yeah.
I don't know if you've got anything to add, Florian.
No, very well explained.
Yeah, and I know very different protocols and standards and institutions. So I know in lots of institutions they use chest CT maybe for acute cases. But again, if you do have these standards, just be aware about the limitations of chest CT. Now we have lots of different questions about PPA, protective equipment for different surgeries, endourology, laparoscopy. Can you just give us a general summary? If we have a patient who is asymptomatic, of course we can reduce the risk, but we can't eliminate the risk of infection. And let's say you have a low number of active viral infections in your country, what would be the appropriate PPE to recommend?
So first of all, you don't know exactly if you put a good measure in place that I explained. If you have a policy of 14-day isolate, swab at the beginning, swab at the end, you know the patient is compliant, you know the incidence of the condition is dropping in your country, you're checking the epidemiology, then you can downgrade your PPE. You don't need to go with full blast FFP3 masks, you can downgrade it to FFP2. And there's even a school of thought that I'm not aware of any publications, but through our discussions, you can wait 20 minutes after the patient is being intubated, and you know that after the HEPA filters have sorted out everything, then you can go in with a simple mask also. So I think giving a one-fit PPE guidance is very, very difficult. It depends on what you did preoperatively, it depends on your theatre space, it depends, can you wait after the patient has been intubated for 20 minutes? So I don't think it's procedure specific, the guidance. The guidance for PPE is specific to the infection prevention measures you took.
Yeah, thank you. And now we have some general questions, maybe also relating to Florian's presentation. Do we have any data about reinfection rates reported? And if there is, what do we know about the immunity of recovered patients? There were some different reports about that as well.
Yes, there are in the last weeks, there have been conflicting reports about immunity and that immunity might not be continuously. I don't think at that time we can answer these questions with really confident sources. So I've showed you the study that was thoroughly done by 10 patients, and they at day 14, all of them, they had a positive serology. We don't know yet how this positive serology or this seroconversion is really effective in preventing the infection. And that is also a very important issue, of course, for the companies that develop vaccination strategies. But there is so much conflicting discussion on that I currently cannot dissect out what is the true evidence. So we have seroconversion, and if we take that into account with other virus infections and other infections, that we know that in most of these patients, seroconverted patient, in most of the people, a seroconverted patient is protected against the infection. So this is our current understanding, and I don't think why it should be different with coronavirus.
Yeah, I agree. But of course, I don't think anybody in the world would have exact answers to these questions. Now we have a specific question. Maybe you have some insight about this. What is the chance to have priapism in a patient with corona infection? Is there anything to add here?
Interesting question because of the recurrent thrombosis. I have not seen a patient, for example, that had priapism, so I can't answer that. So it might be an increased, that he could have an increase, but I don't know if the priapism ratios have gone up. I have not seen any data on that.
Yeah, I haven't read anything about that either. Okay. Zafar, would you always go for screening, isolation for 20 days and swab again prior to the surgery, or just do it after 48 hours? So I guess it's the repeated swabs. So would you recommend it for the long and short isolation as well?
That's a very good question. I think what we done in our own institution, which was the policy I was advocating, 14 days isolation, swab at the end. This is what we do at UCLH. We have audited our data, and out of 500, I think we had only 1% COVID cases, which none of them have developed complications.
Yeah.
But in an ideal world, which I couldn't convince everyone for this, is swab at the beginning, isolate 14 days, swab at the end.
Yeah, and I think most doctors agree with you that we have to do all safety measures we can, screening and protective equipment and so on. But of course, it's always two sides of the coin, and usually, in my experience, at least hospital administrations try to decrease or minimize these measures. Of course, in what is still safe, because they have to also think about big numbers and financial reasons as well. But usually, in my experience, there is some arguments between clinicians and administrators. Is there any document?
I want to add something onto that. It's important to know that we're going through different phases of the pandemic. If we try to screen every patient with a swab, it means that you're utilizing a very limited resource that can be actually used for diagnostics of severely ill people.
Yeah.
So I understand why we had to choose this, and this is a compromise. So we swab at the end, 14 days isolate, swab at the end, and that confirms if the patient was compliant to the isolation. If you came with a technology to me to tell that I know this patient has been compliant for 14 days, I wouldn't swab that patient at the end of 14 days.
Yeah. Okay. And of course, it's highly specific about the situation in different countries. But is there any document or official statement paper maybe you can use, or these doctors can use in these arguments, or is it impossible to give it just a recommendation in a European level? Or are you aware of any general statements or documents which doctors can look up?
Hopefully soon there would be, because everything I presented today was based on a very large systematic review we didn't only take the principles from COVID infection today, we have worked with scientists and infectious disease experts who have dealt with the 2003 outbreak. We have worked with the microbiologists to develop all these statements and guidances. Now, I can't release those in full detail because it's in peer review, these papers we have developed. And hopefully soon, if they get published, we'll be able to share them. And it gives a clear step-by-step guidance how to balance PPE, how to balance each step.
Yeah. Okay, we have time for two final questions. And one is, if a patient is recurrently positive for COVID-19, when should we repeat the test before elective surgery? Is there any difference in the recommendation?
I don't know what Florian will say to this, but just recently, CDC guidance again has said that after a person has become asymptomatic, they need to remain asymptomatic for 3 days in a row. And then you need to swab them at the end of the 3 days to know that if they have any viral load. Now, what is not known, if you detect the virus there, is this contagious or not? 2, what they don't know is that if you put these people through surgery, what's going to happen? Because possibly their lungs have already been infected, they're already being harmed, so it's very early for them to recover from that. Therefore, there's a tiny dip note in the CDC guidance as once the patient recovers, 20 days later, they will be probably fit, come back to the baseline fitness if they recover completely. But that's anecdotal, and it doesn't rely on any solid evidence, I would say. But I don't know if, Florian, you've got anything to add on to that.
No.
Yeah, that makes sense. Thank you. And the final question, if you decide to do the isolation, long or short, should it be as inpatient? Is it better to do it inpatient or at home or as an outpatient?
Good question. So, for instance, China did this as inpatient. Other countries did it as they booked a hotel across the street, if possible, put their patients into single rooms. Some countries might not have the resources for any of these, and you need to keep patients in one room as a cohort room. We did that at the beginning because of limited space we had, but one patient had COVID, then 4 patients had their surgery got cancelled. Theatre gone empty. So I suggest that at the end of all this experience, isolation on their own, isolation at home is the most cost-effective way of doing it, if you can secure safe transport of the patient from home into a hospital.
Yeah, I agree. And of course, you can never be completely sure how much they comply.
Yeah.
Okay. So thank you, Zafer, for providing us very practical answers to all these questions. I think we heard very, very valuable information from both lectures and of course during the discussion. So on this note, I would like to thank you both. Thank you, the speakers, for your presentations, and also thank you all who participated in today's virtual Euro webinar by the European School of Urology.